All right, good afternoon. Thank you everybody for being here at 1 o'clock on Tuesday. I'm Dr. Emily Stockert. It's my honor and my pleasure to moderate this panel on post-dural puncture headache. Post-dural puncture headache is an important and relevant topic to anesthesia practice. It may occur following either intentional or accidental dural puncture. Utilization of neuraxial labor analgesia continues to rise in the United States, with a prevalence of nearly 84% in nulliparous patients in 2022. The incidence of accidental dural puncture with epidural placement is estimated to be around 1.5%. And with up to 80% or more of those developing post-dural puncture headache symptoms, this is a problem that is not likely to go away anytime soon. So while this talk is skewed more towards obstetric practice, it is important to remember that a post-dural puncture headache may occur after any neuraxial procedure, such as a single-shot spinal for a hip or knee replacement, or an epidural for post-op pain control. I have no financial disclosures or conflicts of interest. I am an obstetric anesthesiologist and a clinical assistant professor at Stanford. I spend a lot of time on labor and delivery, and I myself have been an obstetric patient 4 times over. I recognize that my experiences, both in my personal and professional life, shape the lens through which I practice and through which I teach. Lastly, I want to give a shout out to Dr. Jess Ansari and Dr. Pamela Flood, who have been my educators and mentors on this subject. This Snap Talk panel will provide evidence-based practical management tips for one of the greatest headaches, pun intended, in anesthesia practice, the post-dural puncture headache. This known complication of neuraxial anesthesia causes acute pain, increases the risks of severe sequelae, such as subdermal hematoma and chronic headache, and is the leading cause of obstetric anesthesia-related closed claims. We will provide practical, evidence-based suggestions for the prevention, treatment, and follow-up of post-dural puncture headache. I will first go over the epidural blood patch. When, how much, tips and tricks. Then we will hear from Dr. Melissa Cresso about evidence for symptomatic treatments other than the blood patch. Dr. Leziga Obillo will follow with the wet tap scenario, evidence for interventions to prevent headache. And unfortunately, Dr. Grace Lim was unable to be here today, but her talk on applying the consensus guidelines on post-dural puncture headache will be covered by Dr. Obillo. So let's start with a few basics. What exactly is an epidural blood patch? It involves a sterile injection of 10 to 30 mLs of the patient's own blood into the epidural space. The epidural blood patch is recognized as the gold standard for treatment of a post-dural puncture headache. Relief is achieved via 2 mechanisms. First, immediate relief from the pressure effect of the blood displacing CSF back up to the head and reducing the gradient from the CSF loss, and a more long-term relief from the blood clot acting like a bandage or a patch to help seal the defect in the dura. Epidural blood patch is indicated when a post-dural puncture headache is refractory to conservative therapy and impairs activities of daily living. Conservative therapy may include bed rest, hydration, caffeine, and analgesics, and there will be more on this later from Dr. Cresso. But when is the best time for a blood patch? The textbook answer is the optimal time to place an epidural blood patch is generally at least 24 to 48 hours after dural puncture, unless symptoms are severe or disabling, in which case earlier intervention may be warranted. Observational studies show that performing an epidural blood patch within that first 24 to 48 hours is associated with a higher likelihood of requiring a repeat epidural blood patch for symptom resolution. But this conclusion of patch failure is probably a misinterpretation of the data. Patients with a very severe headache within 24 hours likely have a larger dural hole and a subsequent CSF leak, which may predispose that patient to require several interventions anyway, and is not a reason to delay. The realistic answer of when to perform a blood patch is as soon as possible if your patient has symptoms of a post-dural puncture headache and desires treatment. So why do we wait? The delay is likely multifactorial. This decision may be driven by observational data, patient or provider reluctance to needle a back that has already had an accidental dural puncture, and sometimes denial. Maybe it isn't clearly a positional headache, or hope things will get better in a few more days. So if the headache will eventually resolve, why should we consider patching sooner? The most obvious reason is to relieve pain and suffering. And it is possible that an early epidural blood patch can prevent or attenuate the acute and dreaded sequelae of subdural hematoma, central venous sinus thrombosis, cranial nerve palsies, and postpartum depression. An improvement in pain may also increase breastfeeding success, as well as reduce length of stay or prevent readmission. So you've confidently decided to move forward with an epidural blood patch as the best treatment option. How much blood is the right amount of blood? The recommended volume to use in an epidural blood patch is 15 to 20 mLs. This recommendation is supported by the American Academy of Pain Medicine in its 2024 Multi-Society Consensus Guidelines. Higher volumes, greater than 30 mLs, do not increase efficacy and may increase risk of complications such as pain or radiculopathy. Injection should be stopped if the patient experiences significant pain during the procedure. My practice is to draw 3 10 ml syringes of sterile blood and inject slowly, aiming for 20 mLs, occasionally having to stop sooner, and sometimes giving a few cc's more, but never more than 30 mLs. So here are a few vetted tips and tricks. When considering what level to perform an epidural blood patch, an MRI study using 20 mLs of blood showed that it spreads 3.5 levels up and only 1 level down. The epidural space has a pressure gradient with lower pressures at higher vertebral levels, which may explain the preferential cephalic spread of epidural injectates. Thus, it is recommended to perform the blood patch at the same level or below the level of the accidental dural puncture. It therefore follows that at the time of accidental dural puncture, if identified, it is important to document the level of the wet tap to guide this future treatment. Some other considerations: patients generally will need to lie flat for 1 to 2 hours after the epidural blood patch, and it is prudent for them to use the restroom and breastfeed or pump before the procedure. Midazolam can certainly be offered for anxiolysis. Supplies can be gathered and brought to the bedside in a postpartum room, or the patient can be brought to triage, but it always helps to have extras of things. A list of some common supplies that are needed is included here. Strict aseptic technique is critical, no matter what location the epidural blood patch is performed in. And when you achieve loss of a resistance, don't be surprised by a slow drip back from the epidural space. Just ensure that you have negative aspiration from the TUI. And always inject the blood slowly. Pause for back discomfort and try to resume at an even slower pace. And stop injecting entirely if the patient experiences paresthesias. Epidural blood patch truly works for the treatment of post-dural puncture headache. It has more than 60 years of clinical use with overall low risk of significant complications. You can see here that dramatic improvement in symptoms in the blood patch group. And when left to conservative therapy alone, 80% of patients will still have a headache at 7 days. So while epidural blood patch is a safe and effective treatment option, it does carry some risks. Pain at the injection site is very common, and 25% of patients may experience an aching in their back, buttocks, or legs that is similar to sciatic pain and likely caused by a mild arachnoiditis. Others may note neck pain or even vagal symptoms during injection. And of course, there is always the chance of a repeat unintentional dural puncture during epidural blood patch placement. If recognized and the procedure is aborted, the patient will likely have a worsening headache. And if it is unrecognized and the blood is injected, the patient can develop severe arachnoiditis if blood is injected intrathecally. Finally, patient disclosure and education is critical in the treatment of post-dural puncture headache. These are screenshots of our informational handouts that we provide when a patient has a suspected accidental dural puncture or they present with symptoms consistent with a post-dural puncture headache. That's on screen left. And we provide a second handout if they do receive an epidural blood patch. That's on screen right. Both of these are available in English and Spanish to reflect our patient population. We perform a minimum of 3 days of post-headache or post-blood patch follow-up, either in person or via phone call if the patient has gone home. And most importantly, these documents have our contact information if the patient is home and needs to contact our team with further questions. You don't have to reinvent the wheel at your institution. The Society for Obstetric Anesthesiology and Perinatology has a ready-made patient handout that can be downloaded for free with membership. And as much as I am a proponent of epidural blood patches, the most critical component in the treatment of a post-dural puncture headache is shared decision-making with the patient on what is the best path forward, as well as ensuring adequate follow-up. So with that, I will turn things over to Dr. Melissa Cresso.
So I'm going to do alternative management to the epidural blood patch for the confirmed post-dural puncture headache. I'm going to try to discuss the interventions from non-invasive to procedural interventions, and while also discussing the recommendations and consensus recommendations when applicable. So this is a word plot that I created using AI enveloping post-dural puncture headache management with respect to some of the quality of the evidence, excluding the gold standard for this. And as you can see, there are many different management techniques that have been examined over the years. And when there's this many different types of treatment options, usually none of them work very well. I tried to do the same thing again putting epidural blood patch in, and you can see that stands out a little bit more, but still with AI models, it's only 60 to 80% able to do that anyway. But this is a paper, this is a QR code to get to this paper. It is the consensus guidelines from a multi-society international working group that was published last year. If you haven't seen this paper, it really does encompass a lot of the things that we're going to be talking about today in my talk and throughout all of ours. But the regional societies, both from Europe and the American Society of Regional Anesthesia, so the UK OAAOB Society, and several others all participated in this. So moving on to non-invasive interventions, the first one I wanted to talk about is bed rest. There's no published randomized controlled trials examining this effect, but we know that there's a temporary relief of the headache, but prolonged bed rest is undesirable, especially in the pregnant population due to that high risk of venous thromboembolism that can occur, especially in that 6 weeks right after delivery. So evidence does not support routine use of bed rest, especially if it's prolonged to treat post-dural puncture headache, but it may be used as a temporizing measure to get some symptomatic relief. Fluids also are one of those things that there's a single clinical trial noting no benefit to fluid therapy for prophylaxis, but we do know that adequate hydration should be maintained with oral fluids, and IV fluids should be used when oral hydration cannot be maintained. Abdominal binders are thought to work by increasing pressure within the spinal canal, pushing CSF cephalad and reducing the headache, but few data has actually shown evidence for this, and only one study shows benefit. So the recommendation currently is if acceptable to the patient, you can offer it, but doesn't need to be routine for everyone. There's been a single randomized controlled trial that looked at aromatherapy with lavender, and they did get a small but temporary benefit in decreasing the severity for post-dural puncture headaches. This randomized controlled trial had 50 patients randomized into lavender oil or a paraffin solution as placebo, and and it actually did show a little bit of a difference between the two. But the evidence does not support this as routine use, although it is something in terms of shared decision-making. Oral and IV pain medicines, moving on to this. Oral analgesics, there's no real placebo-controlled trials looking at acetaminophen and NSAIDs or even weak opiates, because usually that's bucketed into the control group or a placebo group, and they're included in that and investigating other things. But We do currently recommend, or the consensus guidelines are, for NSAIDs and acetaminophen to be offered as part of multimodal analgesia care for post-dural puncture headaches. And opiates have been shown to have no role in prevention of these headaches, but if the traditional acetaminophen and NSAIDs are not helpful, they can be offered, but only on a short-term amount, and it's not a long-term solution. So they're not recommended for routine use either. Caffeine is one that all of us have been doing for a long time, and I wanted to just go over where that research is. There was a recent Cochrane review that stated that caffeine was effective in decreasing the symptoms, and it had 3 randomized controlled trials involved in that, and 2 of them were in the obstetric populations. And these are a summary of what those were in that, in recent data. So one of them was a randomized controlled trial of 41 patients with post-dural puncture headache, and they either got caffeine IV form, 500 milligrams versus placebo, and showed significant improvement in headache quality within 2 hours after the caffeine. And another randomized controlled trial of 40 parturients had oral caffeine given of 300 milligrams or placebo, and they saw a severity significantly reduced at 5 hours, but no difference at 24. And the same number of people in each group ended up with an epidural blood patch. So consensus statement-wise, may be offered in the first 24 hours of symptoms with a max dose of 900 milligrams per day. And that's the recommendation for everyone, but if you're breastfeeding, then the USA guidelines do go down to a max dose of caffeine of 300 milligrams per day. I didn't want to touch on many of these medications in great form, but they've all been looked at and researched as treatment for post-dural puncture headaches. And they all do show some decrease in severity of symptoms, but there was many weaknesses in terms of small numbers or patient demographics. They were mixing obstetric and non-obstetric patients, age, gender, etiology of the original dural puncture, not really specified. And so it kind of limits their interpretation or potential, and there's potential for bias. So these ones are all currently not recommended for routine use for headache treatment, but they are things that have been researched. I did want to spend a little more time on adrenocortico hormone or corticotropin, partly because I see a lot of questions on social media forums about this, especially in recent years. But the proposed mechanism of this is that adrenocorticotropic hormone stimulates the adrenal cortex to release glucocorticoids and mineralocorticoids. And glucocorticoids have an anti-inflammatory effect that may decrease meningeal irritation, causing CSF leakage after dural puncture. But also, these analogs may also increase CSF production or alter CSF absorption, which potentially helps restore CSF volume and pressure and can alleviate symptoms. So early evidence in the earlier 2000s showed promising evidence of this, but in the last 10 years, there have been more evidence looking at efficacy of these. So I just wanted to mention a couple of the more recent ones as well for people to see. So this was the original study that put corticotropin on the map, where they had 90 parturients who had accidental dural puncture with an epidural needle. And they looked to see if this 1 milligram dose versus placebo could reduce the incidence of post-dural puncture headache and the need for epidural blood patch. And it did show a little bit of promise. And so this is kind of where this started taking off and percolating around. But in more recently, there's been other evidence as well. And this was a randomized controlled trial that was in 2016. And they looked at giving corticotropin and evaluating on day 1, 3, and 7. And they saw that the epidural blood patch was more effective early on day 1, but there was similar efficacy across the board on day 3 and 7. So the conclusion for this particular study, not the consensus statement, is that it can be considered when an epidural blood patch was contraindicated. But just this year, there was another randomized controlled trial with tetracoxsactide, which is a synthetic ACTH. And it had 44 patients in it. They looked at the rate of epidural blood patch within 15 days and then had secondary outcomes like headache intensity and hospital stay. And they found no difference in the epidural blood patch rate, but a slightly longer hospital stay in the treatment group. And the conclusion was a single dose doesn't really prevent epidural blood patch needs in the postpartum population. And I have a little pregnant person in the corner for each research one that included pregnant patients in it as well, just so you guys can watch that too. This study actually was terminated early though, because they thought it wasn't very futile to keep putting people in it, which is why there was only 44 patients, because they were trying to get, I think it was like 90 or 100 patients. But then they decided it wasn't worth trying to recruit more people when they didn't see a difference at the halfway point. So the consensus statement that was published in 2024 says that routine use of this drug is not currently recommended due to limited data and lack of replication in larger studies. So moving on to epidural adjuncts, which the first one of these is saline. 43 parturients have had either a dural puncture as an inciting procedure, either with an epidural needle or a spinal needle. And they had after 24 hours, they had the headache come back, even though they had really good temporary relief. This is another study that showed pretty much the same thing, that they had really good temporary relief initially, but then it came back in both groups at 24 hours. This one was interesting because they also had a saline infusion involved, but it still at 24 hours showed that it didn't really help overall to keep these headaches at bay. So the epidural saline consensus statement on this is temporary benefit, but you should not expect long-lasting relief for post-dural puncture headaches. Epidural and spinal morphine has also been looked at. However, all the studies are really all getting attributed back to one center that's doing all the research. And all this research is over 25 years old. They don't really call out any specific mechanism to relieve the headache. And most of the papers don't really talk about side effects like respiratory depression, where you could see that sometimes they were using doses of intrathecal morphine of 1.5 milligrams over 16 hours. And so without that information about respiratory depression, it's hard to know what to do with this information as well. So currently the evidence does not support use of these, does not support routine use. It's actually not to use it at all is the recommendation. These ones have not been done in the obstetric population at all, and there's very few data on using gelatin or dextran epidurally, and it's mostly coming out of regional and acute pain. But it's also showing that evidence does not support routine use of these. And that's the same with fibrin glue and epidural hydroxyethyl starch. These have not been looked at in the obstetric population at all. But specifically with fibrin glue, some of them, patients who have had this have been getting anaphylaxis or aseptic meningitis as well. And I wanted to move on and spend more time on this, the procedural intervention part. Sphenopalatine ganglion blocks had a moment for this a couple years ago, especially right after COVID. But they were first described in 1908, and the mechanism is really about blocking parasympathetic outflow from the sphenopalatine ganglion. And then it causes cerebral constriction to downregulate inflammation at that area. But there's been mixed evidence on it. And the supporting evidence is really coming from 5 observational studies and several case series and some reports. There's been equivocal evidence or no benefit in 1 meta-analysis, a 1 randomized controlled trial, and a systematic review. It's been hard to actually extrapolate things around this because there's been such heterogeneity in patients. There's difference in techniques because you can do this with an applicator, you can do this with spray, you can do this multiple different ways. The amounts that people are using and other management options that were also being used at the same time. So it's really hard to look at all of this together and decide what should be done. So the current consensus right now is that the evidence does not support routine use for sphenopalatine ganglion blocks to treat post-dural puncture headache. But if you are to do it or were to do it, there's a single randomized, single-blind comparison trial of transnasal sphenopalatine ganglion blocks in obstetric patients. And they used either the cotton swab applicator versus spray. And it found that the cotton applicator was better if you were going to do this than the spray. Although, you know, when this was having a moment and there was some suggested research that maybe it was another alternative technique, my center did do this quite a bit during that time. And we found that all the patients hated it, at least at our center. They loved it initially and were like, this is great. And then the second the lidocaine went away, they were just as miserable and they just felt like it was futile to go through it. So even if you would offer it again the next day, they just hated it. So we went away from this very quickly at that time. But this is kind of the newer one, which I'm not sure if everyone has seen, but there's actually evidence on this a little bit more too. But greater occipital nerve blocks, the greater occipital nerve is a branch off the C2 dorsal ramus, and it carries sensory to the back part of the scalp. And it's thought to work because these headaches are from a CSF leak, that the low pressure setting and the sagging meninges, it can take off some of that pain. So these are usually performed bilaterally with a mix of local anesthetic and steroid. And there's been 5 randomized controlled trials, not all in obstetrics, a systematic review, and some other studies as well. I'm not going to go through all of these for the sake of time, but I just wanted to kind of put them up here so you could see them. But this one was done in obstetric patients, and it was done after cesareans. These were small gauge needles initially for the inciting procedure. They did this with ultrasound, and they showed lidocaine and dexamethasone versus saline as placebo. And they saw significantly better headache relief than control at 24 hours, and nausea resolved in all patients receiving these. But none in the control group showed improvement. This was one in non-obstetric patients, ultrasound guided, also showed pain scores that were significantly lower. Ultimately, an epidural blood patch was performed in 6 in the control group. They did note that there was some site hematoma or dizziness, but they thought that this was effective in a lot of patients that didn't go on to get an epidural blood patch. This was a mixed group of surgery patients, non-obstetric again. They did nerve stimulator, greater occipital nerve blocks, a mix of medications. Did find that the headache resolved completely in 68% of patients after getting 1 to 2 injections, but all patients had relief after 4 injections. So this maybe is a place for more research. Maybe we need to see if multiple ones are necessary for people. And in the conservative group that didn't get these, they found that 8% had complete relief after 2 days, and it raised to 36% after 4 days. So it did help a lot of patients. This is another one kind of showing similar things. And this is one in pregnant patients, again, landmark guided. They use lidocaine and steroid against bilateral sphenopalatine ganglion blocks with the same mixture. Both reduced pain, but no difference between the groups at 24 hours. And I found this one pretty interesting because it's an observational study, and there was 24 patients who had inadvertent dural punctures with an epidural catheter insertion. 19 patients failed conservative therapy and ended up having a post-dural puncture headache. And so then they gave them the option of getting an epidural blood patch or a greater occipital nerve block with lidocaine and dexamethasone. 1 patient chose an epidural blood patch. 18 patients chose greater occipital nerve blocks, which I was kind of like, that's interesting. The one that we know a lot about, or this other one we can try. And I think this is where the importance of shared decision-making comes in. Because maybe people are not willing to go through that procedure again if there's something that could help them, but they might need to go on and get the other procedure anyway. But what they found in this study was 6 had partial symptoms relief and were treated with epidural blood patches. 1 patient had a recurrent headache and still did not want to get an epidural blood patch and went on to get greater occipital nerve blocks again and had complete relief. And then 12 fully resolved with the single time of injections. And this is a retrospective analysis that just showed that, again, that 27 required 1 course of blocks, 15 needed 2. So maybe we need more research about repeating the doses. And most of these though, and this is another one kind of showing the same thing. So really with the exception of 1 observational study, which is the one I kind of talked about the shared decision-making, all of these were done with spinal needles as the inciting procedure. And with the other study, it was an epidural needle. So there's definitely a difference in what kind of hole was probably causing the headaches. But it's hard there was variance across the board with these, but it seemed that most patients who had greater occipital nerve blocks collectively seemed to have an improvement in symptoms, although 25% ultimately required an epidural blood patch. So the recommendations right now are the efficacy of this is that if it's a wider gauge needle, it's unclear if it's going to help. But at least with a small gauge needle, so spinal needles of 22 gauge or lower, it could be a thing to offer patients, or it may be offered. But there's going to be a portion of them that are going to need to go on for an epidural blood patch anyway. And this is just the consensus statement infographic that's also out there kind of summarizing this article. So I just wanted to call attention to it. And then I just wanted to talk a little bit about how to do this because I felt like it's new enough that there might not be as many people who know. But really, these are pretty easy to do. You just find the occipital protuberance, which is right here in the middle of the head, and you kind of go back and look at the lower lobes of the ear. And then just a little bit slightly paramedian and caudad, you'll find that's where the greater occipital nerve tends to end up. This can be at different depths in people. So, I would prefer to do it with ultrasound, but there's definitely landmarks that have been prescribed or other techniques. So I just wanted to show how you would hold the ultrasound probe. So it's on an angle toward that occipital protuberance. And then people generally have described an out of plane view, especially if you go to Nysora, which is great to look at new blocks. So when you do that, this is the picture you get. And the OCIM is the obliquus capitis inferior muscle. And the muscle right above that is the semispinalis capitis muscle. These 2 white arrows are really showing compressible veins. And then the yellow arrow is actually the great occipital nerve. So if you look, you can kind of see there's a distinct muscle difference between those two muscles. And that's kind of what you're looking for, so you can target to put the medication. And this is just a summary of everything I talked about, where it just shows that we don't support, the consensus statements don't show support of use of epidural or spinal morphine at all. The next one is not support routine use, but these are things in that category. And then the evidence supports these things for post-dural puncture headache. And that is what I have. So thanks. This is just a plug for our SOAP meeting in Montreal.
Hello, everyone. Good afternoon. I am Lesga Obio, and I'm an anesthesiologist at the University of Chicago. As the final presenter in this talk, I will talk about management, prevention, and process control of PDPH by applying the consensus guidelines. And this talk will be a combination of two topics in the SNAP Talk series, and I would also like to thank Dr. Grace Lim for her collaboration for this portion of the SNAP Talk. Right, these are learning objectives that I have, describing the clinical features, which Dr. Stockert did a great job of talking about with unintentional dural puncture. Also determine appropriate evidence-based techniques to prevent a post-dural puncture headache, and also ways that we can apply the consensus guidelines. So to start my talk, I want us to get into the mindset of being on the labor and delivery service. So you've had your cup of coffee, you receive sign-out from the overnight team, and shortly thereafter your phone rings and you're called to a labor room for a patient who's uncomfortable and requesting her epidural. So as you walk into the patient room, you introduce yourself as the anesthesiologist or the anesthesia provider who will place her epidural. You discuss the risks, the benefits, and treatment options, and the patient consents for an epidural. You get your equipment ready, you prep the patient, and start working diligently on placing her neuraxial. Things go well until you see CSF backfilling through your tubing needle, and you feel really crappy inside. And you keep calm, but you're feeling terrible inside, and just like Mike from the office, you feel like this. So an unintentional dural puncture, which we classically call the wet tap, as a quick reminder from Dr. Stockert's talk, so wet tap is an unintentional dural puncture from the 17-gauge tubing needle that creates a dural defect, permitting the backflow of CSF from the subarachnoid space. And so you've wet tapped your patient and you're deciding what do you want to do next. The first thing you consider is placing an intrathecal catheter. There is some accepted and possible benefits that the rates of intrathecal catheter use following a wet tap have increased in recent years. There have been surveys of anesthesiologists that practice in the United States, the UK, and Australia that note that the rates of intrathecal catheter placements have increased from 18%, 28%, and 35% respectively across these different nations. And although intrathecal catheter use has become more common, reattempting to place an epidural at an adjacent interspace remains the preferred action following a wet tap. And ultimately, regardless of your labor neuraxial analgesic technique, it's prudent to disclose the complication and monitor the patient for PDPH symptoms. Unfortunately, during post-delivery rounds the next day, you learn from your colleague that your patient reports symptoms suggestive of a PDPH. So in reviewing of this PDPH, remember it's a pathognomonic for it being an aggravation of symptoms in the upright position with the relief in the supine position. And as Dr. Stockert beautifully described for us, this headache has various associated symptoms and complications if left untreated. Therefore, delay in treatment of PDPH is problematic because a debilitating headache can lead to maternal incapacity to care for her newborn. Why does PDPH matter? As we all know, that epidural analgesia use is increasing in obstetric deliveries in the United States, and PDPH is a complication that occurs between 1% and 5% of neuraxial procedures across the board. And while many of us have historically thought of this as simply an inconvenience, current evidence, as we've seen, paints a more sobering picture. PDPH occurs in up to 80% of parturients who experience an inadvertent dural puncture during their epidural catheter placement. And importantly, in obstetric anesthesia, PDPH remains the leading cause of closed malpractice claims. So prevention isn't just about patient comfort, it's about safety, long-term maternal health, and reducing liability. Today's talk emphasizes a systematic approach to control the process of managing wet taps and PDPH. SOAP, ASRA, in collaboration with many other societies, created the practice guidelines that we've talked about today in today's talk, and I'll just review the evidence-based recommendations for the management, prevention, and process control for wet taps. And so these are the recommendations that I'll start off with talking about for management. And these are basically Class A and Class B recommendations when for PDPH when it actually occurs. And as Dr. Stockert talked about the efficacy of the blood patch, this is just a reiteration about the blood patch is the most definitive treatment for a epidural blood patch. Van Kooten and colleagues conducted a randomized controlled trial that compared the efficacy of a blood patch versus conservative treatment. As you can see here on the table on the right, the top line of the patients who received a blood patch, and you can see the probability of recovery is much higher in those patients versus those who had conservative treatment. And unfortunately, even after 7 days, the patients who had conservative treatment still did not experience a resolution of their headache. So these are the recommendations relating to prevention, and there are 2, level A, and we'll go through those. So if we learned from Dr. Cresso's talk, prevention of bed rest is not necessarily helpful, so the consensus guidelines do not necessarily recommend routine bed rest and aggressive hydration in patients that already have a PDPH room known wet tap. Some low-hanging fruit that research has looked into is thinking about replacing the CSF volume. Dr. Stockert talked about this as well too, about a study that gave some sterile saline, and they saw some reduction in the incidence of PDPH and a decreased need for epidural blood patch. And they also talked about, another study looked at replacing the stylet in the needle before you remove it with hopes to prevent the wicking of the arachnoid coming from through the epidural catheter. All in all, the expert consensus does not recommend using these 2 techniques for preventing a PDPH in the event of a known wet tap. What about intrathecal catheters? I mentioned that as an option that you can do when you're at the time of placement. So there are some small studies that suggest benefit. Hessen performed a meta-analysis of 9 studies that concluded that intrathecal catheter insertion following a wet tap statistically does decrease the incidence of PDPH, but it's not statistically significant. However, it is statistically significant to reduce the need for an epidural blood patch. The risk and benefit of an intrathecal catheter depends on many things, your institutional culture and patient factors. Thinking about whether the difficulty of placing the block, one might consider placing an intrathecal catheter if the block placement was very challenging. What is your institutional comfort with intrathecal dosing, as well as the anticipated time for delivery. All in all, the expert consensus does not recommend this as a routine prevention of PDPH in patients who have a known wet tap. What about the prophylactic blood patch? There's the impressive efficacy of the epidural blood patch when used as treatment for PDPH has fueled interest in the technique for prophylaxis. Research into the efficacy of the prophylactic blood patch has yielded mixed results, and closer scrutiny indicates that optimism should be guarded. The strongest investigation to date was a prospective randomized control study in 64 parturients comparing the prophylactic epidural blood patch to a sham procedure performed by Dr. Scavone and colleagues. In this study, an identical 56% of patients in each group went on to develop a PDPH. Although there was a trend toward fewer therapeutic epidural blood patches performed in the prophylactic group, the difference was not statistically significant. The primary benefit of the epidural blood patch is a shorter duration of symptoms from a median time frame of 5 days to 2 days, and consequently a reduction in overall pain burden for the patient. With such inconclusive support, the prophylactic epidural blood patch is not currently recommended as routine measure based on available evidence. There's also concerns of exposing patients to a potentially unnecessary and marginally beneficial procedure. A prophylactic epidural blood patch has declined substantially in recent years. And so the expert consensus does not recommend this as routine practice for the prevention and or treatment of a posterior puncture headache. Dr. Cresso talked about the study of using cosentropin and gave us a beautiful illustration of the mechanism of action of this drug. And so there have been studies we talked about that have looked at using this as a prophylaxis for PDPH in a known wet tap. As you can see here, 69% of the patients had a PDPH in the control group versus 33% in the cosentropin group. However, you can see a non-insignificant component of those patients still went on to receive a blood patch for the definitive treatment for their PDPH. So while this may not be a recommended prevention in the setting of a wet tap, there may be clinical scenarios where one can consider this approach, and Dr. Cresso talked about that beautifully for us. And so the cons for this would be the cost of the medication. Many patients report experiencing steroid rage and insomnia, so those may be reasons to avoid using this medication. But as I mentioned before, there may be scenarios in which an epidural blood patch is contraindicated, such as your Jehovah's Witness patient or a patient on anticoagulation, and this could be a nice temporizing option for patients who you may be concerned for them having a PDPH happen in a known wet tap. The prevention guidelines from the consensus are stated here. Basically, for technical guidelines is using the smallest gauge spinal needle that you can. The Quincke needle has the highest PDPH and epidural rates compared to the Whitaker, the Gertie Marks, and Sprott needles, which are usually used on our obstetric services, which are the ones have lower PDPH and epidural blood patch rates associated with their use. Procedurally, we can consider the need to make escalation policies to limit the number of attempts. For example, if a trainee has difficulty, there should be a structured escalation policy to a more experienced provider. And importantly, if an unintentional dural puncture occurs, the guidelines emphasize immediate disclosure to the patient, careful documentation, and a structured follow-up. These are all strategies that require institutional reinforcement, not just an individual's knowledge. Finally, we'll move on to talking about process control when a PDPH does occur at your institution. Before I show you these ideas that were implemented at 2 different institutions, I think it's important to step back and think about the process control more broadly. Drawing inspiration from Lean and Six Sigma quality improvement frameworks, 4 principles apply here. First, we need to standardize, whether that's by creating protocols, paperwork, and escalation rules to practice isn't left to memory or chance. Secondly, it's important to measure, track not just the events, but whether the disclosure and follow-up has occurred for the patient. Thirdly, feedback and correction, using our quality assurance dashboards and case reviews to identify gaps and then close them with targeted education. And finally, sustain and improve. Prevention is not a one-time project. It requires continuous monitoring and a culture that reinforces best practices. And this is a framework that allows guidance to move from theory into reliable practice. So at my institution, the University of Chicago, we realize prevention and process adherence begins with documentation. So we've embedded in our standardized section of our OB neuraxial block note that specifically prompts the provider to record whether a wet tap occurred. And when selected, it links automatically into our notable events reporting system, making it harder for a case event to slip unnoticed. Secondly, the providers add the patient to our X-Files list, which is an internal report that allows the OB anesthesia team to follow up patients with progress notes. And finally, any patient that had a wet tap and or a PDPH is added to our REDCap database to allow for quality assurance reporting. Similarly, UPMC, which is Dr. Lim's institution, also has a procedural documentation workflow, which I'll talk about as well here. And this is a description of their documentation. So first, an epidural placement form that specifically prompts the provider to record whether a wet tap occurred, similar to what we have at the University of Chicago. If it's marked, it automatically feeds into their QA reporting system. And then they have a communication tool that also has an item checklist that informs them for disclosure and documentation. And then another standardized form that's linked to the electronic medical record that is used for follow-up encounters. And if an epidural blood patch should have happened, this is part of that process as well too. These are 2 institutions that demonstrate that embedding this complication into their documentation and processes turned out makes the process much more consistent. And so it takes out the variability of whether it's documented or not. Looking at process control, both the University of Chicago and UPMC have a very similar stepwise wet tap workflow. First and foremost, the patient is informed right away using consistent disclosure language that we teach, that is taught to the trainees and all of the OB anesthesia clinical staff. The event is documented in the patient's electronic medical record within the block note. Follow-up is scheduled systematically, not just when the patient's in the hospital, but also followed up with a structured phone call after discharge. And lastly, if PDPH symptoms do develop, there is a pathway for a timely epidural blood patch placement and a reactivation of the follow-up pathway for symptom resolution. At UPMC, these events are tracked in their quality assurance process, and every unintentional dural puncture with every epidural, PDPH that requires an epidural blood patch is entered into their QA dashboard. But they also go further than us. They monitor the timeliness of disclosure and whether follow-ups were documented, and this allows them to identify patterns. For example, at UPMC, there was a concern that certain shifts or sites have higher rates of underreporting, and that became a topic for targeted education. UPMC ran reports with this QA concern, and the results shifted the conversation from blame and shame to process improvement. It helped to ensure that there was an adherence to the guidelines as measured and not just assumed. And so here on the far right is the graphic showing the total deliveries at UPMC, the neuraxial placement, the estimated PDPH rate at the time between between 2020, and 2023. And you can see here that there was some discrepancies about the percentage of PDPHs that were occurring based off the date of the procedure as well as the time of day. And based off of them having done a QA reporting and monitoring, they were able to basically make some consistency across the practices across the day and time, so that no matter whether it was nighttime, day shift, the staff that was available, there would be adherence to this policy and practice. UPMC and other institutions have also learned that prevention extends beyond technical skill. System-level interventions drive reliability. Standardized paperwork reduces variability. Quality assurance dashboards ensure that adherence is visible and measurable. Education models keep everyone aligned, whether you're a resident, a CRNA, or faculty. And perhaps most importantly, fostering a culture where disclosure is expected and patient partnership is valued makes the process sustainable. These interventions are relatively low cost, but have outsized the impact on patient safety and quality. Implementation is not always smooth. Many years ago, many of our institutions suspected, and specifically at UPMC, that there was an underreporting of the wet taps that were occurring because people were hesitant to self-report. And I can imagine the suspicion is not just exclusive to UPMC. So what did they find? They found there was a variability in how clinicians disclosed the complication to the patients. Some clinicians said too little, others gave explanations that frightened the families. And so therefore there was an opportunity to standardize the language and provide coaching on how to disclose this complication to patients. Another lesson that was learned was that the QA data entry was quite burdensome. And so when they were able to automate portions of the QA data, it made it much more of a streamlined process, and that we're able to get that information straight from the electronic medical record into their QA monitoring systems. And lastly, they learned that continuous reinforcement is necessary. So they bring this up every month at their faculty meetings, and every year when new trainings arrive, there's another opportunity for education, so that such that old habits do not creep in. My encouragement to everyone is to be brave and take the steps to investigate the situation at your institution, recognizing these challenges as part of making a process control system sustainable. In conclusion, I want to emphasize 4 points. First, prevention begins with technical choices, needle type and limiting attempts. Second, process control ensures that once a wet tap occurs, patients don't slip through the cracks. Third, embedding guideline recommendations into paperwork and quality assurance makes adherence reliable. Finally, the most important factor is culture. Create a culture where disclosure, follow-up, and patient partnership are expected. The consensus guidelines gives us the evidence. Institutional processes give us the power to deliver on that evidence. Thank you for your time. And I would like to take one final plug to attend our 2026 SOAP annual meeting in Montreal for those interested in continuing discussions about clinical obstetric care. And this slide contains details about our conference, and we look forward to seeing you there. Thank you for your time.
Okay, thank you, everyone. We're happy to take any questions.
Okay, so it seems to me that, everything that we've talked about today revolves around the dural rent, and that everything that doesn't contribute to sealing that hole in some way, shape, or form is all peripheral and sort of symptomatic. So, one of the slides said that 70-80% of PDPH resolves within 7 days. And then they talked about how conservative treatment after 7 days, a lot of people still had symptoms. So my question is, and then at 6 weeks, it said that 80 to 95% resolved. So do we have data that the dural puncture heals on its, the dura heals on its own and kind of closes off the hole, number one. Number two, when you put a blood patch in to seal the hole, how long before that resolves, or does that kind of stay there for, quite some time? Do we have any information on that either?
In terms of the second part that you had, the symptoms of after a blood patch can sometimes include lower legs issues or pressure in the back. And I think we don't really have data that shows how long or those kinds of things, but I feel like the symptoms, those patients who are having symptoms for a week or 2 or 3 weeks after, probably are having them because that blood is still there and it hasn't fully reabsorbed yet. And I think that there is some data about CSF and mixing with blood, and it forms a clot fast, but the more CSF that's mixed into that clot, the weaker the clot actually is, which is why it's important for people to not do jumping jacks afterward or those kinds of things. So probably a little bit of the percentage of people who have recurrence of a headache after an epidural blood patch probably had that clot dissipate off. But we don't really have data in terms of imaging. And I think it's hard to do studies on that since people don't really want radiographic imaging, especially, postpartum that much.
I think related to your first question, it's understudied, and we have now modified our protocol to send every patient to a chronic, if they develop a posterior puncture headache and we treat it, we send them to a headache specialist for long-term follow-up. I think a lot probably depends on the hole and how big the hole is and how the body is able to close that. If it's a TUI needle that's gone through and through, we've actually had to send people to our interventional pain doctor where they do under fluoroscopy and patch anterior and posterior to try to seal up the defect. So we do know that some patients may end up with a chronic CSF leak, although that tends to be much more rare. But yeah, I think it's an area where we need to continue to focus and better understand what the propensity to chronic headache is and what exactly is the time course for healing.
I also think, the mechanism of if you're having headaches before matters a lot as well. And I don't think we have great research on what headaches people had before that are more likely to then have symptoms after an accidental dural puncture hole, and how long that's going to last. And I'm specifically talking about patients who have Arnold-Chiari. We've had 2 patients at U of R who I just happen to be friends with, and that's why I know this, but they had chronic headaches when they were kids and chronic headaches as a teenager, and they were just something that they lived with their whole life. So they never really thought about it that much, and they maybe got a little bit better as they got older, but they were doing behavioral things to stop that. They didn't have Arnold-Chiari. There was no diagnosis of that. They both had epidurals and they both had accidental dural punctures, holes. And then they ended up with like really bad, significant headaches, worse than where they were as teenagers. And they were lasting for like 6 months after delivery. Both of them ended up going to, neurology and ended up having Arnold-Chiari diagnosed after. And, one of them had to get the surgery, actually. She just went through it in April. And then is getting a shunt placed now. But I kind of feel like that's something that we don't always know about because there's a lot of people have Arnold-Chiari walking around. And I think a lot of them have headaches that they just aren't really disclosing to us because they live with it all the time. Or they're just not having that many symptoms because they've done behavioral things to control them. And so I think that's an looked at area. And that might be where some of the prolonged headache stuff is coming from. But you have to go back to the mechanism of the initial headaches that someone was having before, and then look at that as well.
Sorry to hog the mic. 2 other observations. I've had 2 patients in my entire career that had a blood patch, and one of them was driving and came to a stop sign and reached over to grab something and felt a little pop in the back where you can break the clot. And so, you wonder how long you have to kind of go on light duty. I usually have told them 24 hours, and that seemed kind of reasonable, but, maybe it might even be a little bit longer than that. The other observation is, and this would be super aggressive, but, spinal surgeons a lot of times will put a big tear in the dura and they just go in and sew it up. And I'm wondering, if you had a really bad hole and someone had really bad symptoms, if that might not be something that could be looked at in the future. It's very aggressive, I agree.
When I think of the most dramatic ones that we have had, we had a patient who ended up with a known accidental dural puncture. We performed a blood patch early. She had very bad symptoms less than 24 hours later. We ended up doing a second one. And then she actually came back in with an unrelenting headache. So we sent her to the scanner and she had a subdural. And so at that point, we're like, we're done. This is out of our expertise. We involved the interventional pain doctor, and he had actually identified she had a through and through injury. He was able to repair it doing paramedian approach and, like I said, doing ventral and dorsal blood and fibrin glue, but that's pretty extreme. But I think to your point, people can have a significant defect in the dura. Fortunately, those are more rare. I'm not aware of anybody that we've had to send for neurosurgical consultation. Obviously, that'd be far more invasive, but it is something to think about.
Yeah, thank you guys all for coming for this last session.